Thank you, everyone. Please do be aware that our exits, our emergency exits are straight out this door. We appreciate you coming today.
Welcome everyone to the class of 2022 thesis presentations for our graduate students in the medical and biological illustration program. I want to also welcome and thank our YouTube audience who is watching us live. This is a major achievement for these 6 students, the culmination of work on their master's thesis. They each conducted original research and created a solution to a visual biocommunication challenge. Unlike most graduate programs, our thesis preceptors are faculty in other departments in the School of Medicine who proposed research questions to our students on a variety of clinical and scientific topics. That's what makes it so fun for us to be in the audience today. We get to see visually stunning presentations and gain new knowledge and understanding on diverse topics. Each student has evaluated the problem presented by their preceptor, become an expert in the subject matter, designed a solution for a specific audience or audiences, developed and iterated on that design to create a prototype, a proof of concept, or complete visualizations to address the challenge originally presented, submitting a written thesis approved by the Eisenhower Library, and prepared a 10-minute presentation for us today. Each student will take a few minutes to answer questions following their presentation, and we encourage you to ask questions. You can raise your hand for the mic, or folks in the YouTube audience can type their comments into the comment section, and we will call those out. Our first presenter today is Gabby Rivera Del Rio. She received her BS in biology from Florida International University with minors in art and English. Gabby became interested in evolutionary biology during her undergraduate years, and she developed her interest in user-centered design, often referred to as UI/UX, while within our graduate program. We'll see these 2 passions united in her thesis presentation.
Good afternoon, everybody. Let's get this show on the road. All right. Thank you. My name is Gabby Rivera Del Rio, and I'll be presenting on rethinking the evolution of temporal fenestrae in turtles, an interactive app for comparative anatomy and phylogenetics. I worked on this project with Dr. Gabriel Beaver and Tim Phelps. Where did turtles come from? This question is among the oldest and most debated problems in vertebrate systematics. Over the years, the hypotheses have run the gamut for where they land on the amniote tree. But recent studies indicate turtles evolved within the diapsid radiation, comprising all other living reptiles and birds. This group is defined by the presence of 2 temporal fenestrae, or openings in the temple of the skull, as shown in yellow. But turtles are anapsid. They have no temporal fenestrae. If the inferred change from a diapsid to a secondarily anapsid condition are true, then in keeping with this morphological trend, the fossil record is expected to yield a transitional form, a turtle relative with a diapsid skull, if you will. Enter Unitosaurus africanus, a 260 million-year-old turtle relative that predates dinosaurs. It exhibits many traits that help reconcile the gap between turtles and their diapsid cousins, but how it does so is misunderstood. While superficially different from the classic condition of diapsids, the Unitosaurus skull does have an open lower temporal fenestra and a smaller superficially covered upper fenestra. In all, it represents empirical evidence that supports the molecular data placing turtles as diapsid in origin. This communication challenge is twofold, represented by very few visuals, for one, and 2, conceptualizing its evolutionary importance is complicated. Evolutionary outreach is often impeded by pervasive intuitive biases and misconceptions that abound even in academia. In fact, multiple nationwide educational initiatives have been funded recognizing the importance of evolutionary thinking to the life sciences. The objective then was to communicate what this fossil adds to our current knowledge in conformity with pedagogic standards. The primary audience for this work includes post-secondary and graduate students and their professors. This was realized in 2 phases. The first was to visualize this taxon through novel digital reconstruction of the Unitosaurus skull in the tradition of other paleontological work, as a resource for public outreach and further study. The second was to contextualize this fossil in a web application that communicates its scientific importance and teaches evolutionary concepts. On to methods, we begin with the novel 3D reconstruction. Previously, the Inodosaurus skull was something of an enigma, thanks to poor preservation. Fossils are often found bearing the marks of eons of geological, chemical, and physical forces that distort their shape. Think breakage, compaction, shearing, and so forth. After identifying these distortions, they can be undone using several techniques. Mirroring and averaging leverages the bilateral symmetry through reflecting elements across a mid-sagittal plane and averaging the positions of landmark features on either side. Repositioning restores broken fragments and rejoins disarticulated bones. Oh, whoop, skipped ahead. Superimposition builds composites from unequally preserved structures across the mid-sagittal plane, and plastic retrodeformation attempts to undo changes like bending, torsion, or warping. Extrapolation is also used where possible, but sparingly, so as to not introduce too much error. Lastly, having other specimen on hand as a reference and source for missing components is valuable. But due to lack of other well-preserved data in this part of the tree, I could not exercise this last option. For phase 2, I focused on contextualizing the taxon through the reconstruction in a web application, the design of which was informed by macroevolutionary science pedagogy. These concepts are underrepresented in American biology curricula, and yet are the most needed to understand how fossil finds contribute to modern science. Without this level of consideration, users can walk away with lingering misconceptions. Take, for example, the very common progressionist notion that evolution is a linear process occurring across a main line from which sister taxa arise as offshoots. This can be summed up by the question, if humans came from chimps, why are chimps still around? In reality, modern chimps are as far removed from their shared ancestor with us as they are, with our shared ancestor with them as we are. We can fix this thinking using the visual language of our tree. First, let's replace the V shape with right angles, which more clearly demonstrate the concepts of common ancestry and divergence events in evolutionary history. But this can still be improved. Right now, we have a ladderized appearance, which can still reinforce some biases, like reading left to right, so E is mistaken as more advanced than A. So let's rotate those nodes. Much better. This format forces learners to use the connections made through the diagram, rather than read across the tips or up the ladder, as it were. Several software were used in this project. The 3D reconstruction was done in Cinema 4D and ZBrush. The 2D reconstructions and assets were made in Photoshop and Illustrator. The design and prototype for the application was built in Adobe XD, and screen recordings taken with QuickTime. Animations were made in After Effects and exported via Media Encoder. For final results, let's start at phase 1. I think a before and after is in order. So first we have a turntable of the original fossil segmentation taken from CT data. Despite the extensive damage, this specimen is the largest and most complete skull of this taxon, first described over a century ago, but never modeled digitally until now. Before work could even begin, days of intense observation were needed to model how the ages have deformed the specimen. Identifying and recording these is crucial to ensuring a successful reconstruction. We need to understand the deformations before we can undo them. With the final product, I restored bilateral symmetry and corrected the extensive deformations while retaining and restoring important bony relationships. Here, we can appreciate the 2 temporal fenestrae in yellow. Lifting out the supratemporal bone reveals the upper fenestra, which in the juvenile starts out as large and open, but is reduced by expansion of surrounding bones in adulthood. This developmental change may reflect the larger phylogenetic trend towards shrinking fenestra later in the turtle lineage. This phase marked the major scientific contribution of my work, as every reconstruction is a hypothesis constituting interpretations of the morphological and functional constraints, symmetry, and level of deformation. Preserved bones and fragments can align in myriad ways, so sticking to evidence-based adjustments is crucial to mitigate errors. I'll go into the importance of this in my discussion. For phase 2, I mocked up the prototype application. I've prepared a screen recording from Adobe XD for your viewing pleasure. In the Morphology tab, users have an interactive 3D model viewer that allows them to explore the complex skull architecture. Its interface is consistent with other popular model viewers, leveraging user familiarity to create a smooth experience. This section mostly engages users in comparative morphological analysis, a practice that forms the basis for inferring evolutionary relationships and trends. The information panel describes the taxon the user is observing, in this case, Unitosaurus. The phylogeny tab places this fossil in a broader evolutionary context. The 2D reconstructions themselves use shading to convey spatial information about the midline cranial structures, which are often left out of the primary literature. This is intentional, as these features in Unitosaurus inform its relationship to turtles. With students in mind, this cladogram features descriptions that link to educational modules and is itself interactive, visually reinforcing phylogenetic relationships. The information panel in this section dissects the part of the tree that they've selected. The floating navigation allows even more interactions, giving users the ability to map character changes across the tree. They can also expand what is mapped on the cladogram and change how it presents its information. So really, every cladogram tells a story, and this one is no different, with the taxon selected to tell the story of changing temporal fenestration in this group. Finally, the Resources tab has articles that summarize the main contributions of this discovery, with references from more knowledgeable users. This constituted the major didactic hurdle of my thesis, as the information design needs to incorporate best practices in communicating evolutionary theory and concepts. In the end, I achieved several things. I created a novel 3D reconstruction of the Unitosaurus skull. I also created a first-round design of an application that uses turtle evolution as a problem set to teach comparative morphology and phylogenetics. And as part of this problem set, 5 additional modified 2D reconstructions of extinct reptiles were created. This did bring some challenges. As the first of its kind, and in a famously sparse part of the fossil record, this work was reliant on descriptions that span a century. No comparable specimen could be referenced, hence the need to extrapolate certain features. Moreover, it would have been great to have access to more efficient software for retrodeformation, such as Landmark or Aviso. C4D was great, but it required manual averaging of the values and landmarks. For future directions, the reconstruction composes a vital asset for finite element analysis. This technique reconstructs the load adaptive remodeling of bony structures like the skull. As a fossorial or burrowing animal that would have used its head to brace itself while digging, could the stress induced by this behavior explain why Unitosaurus, quote unquote, loses its upper temporal fenestra in adulthood, or has a superficial covering of that fenestra? Or even why modern turtles lost their temporal fenestra entirely? This reconstruction could be used to answer such questions. Additionally, the design and content of the application could use further rounds of development. I'd like to thank Dr. Beaver for his time and attention, Tim Phelps for his guidance, Jeff Day and Jenny Fairman for their feedback, and the Vesalius Trust for funding this work. A special thanks to friends, family, and colleagues for their support as well. Thank you all. I now welcome comments or questions.
We do have a question from our YouTube audience. Alumna Laura Eckel says, what structures normally go through the fenestrae in dioptic or this guy? Muscles?
Should I repeat the question? All right. So I think everybody heard it. That's a great question, Laura. Usually, so this part of the temporal region is what we call the adductor chamber. So the adductor muscles usually go through here.
Hello. This is amazing how much you got done during the thesis, Gabby. Just looking at these images of the midline structures, you said they're usually not illustrated. Did you have to figure out and illustrate all the other animals as well as your animal, or did you have references for other ones?
So yes, thank you. That's a great question. I did have to piece these together from various sources because as I mentioned, the primary literature, it's usually focusing on either the surface features or the fact that there are those fenestrae. So the midline structures were often left out, but I was able to find some good papers that helped me describe them. In particular, one about the Jungina brain case. Jungina is the second one in the order here. I was actually initially going to use another Archosaurian here. This is Mesosuchus, but I couldn't find sufficient information for the midline structures there, hence the change. A correction, I said Archosaurian, it's an Archosauromorph. Shame, shame. All right, thank you.
Jason Brady, our next presenter, is a classically trained fine artist. He received his BFA in sculpture from the Lime Academy College of Fine Art, has exhibited internationally, and is represented by a gallery. Jason is also a serious scientist, a phenomenal researcher on display in this thesis. Jason is unable to present in person today, but we will view a pre-recorded session. I need some assistance. Oh, I got it. Wait a minute.
Hello, this is the disembodied voice, Jason Brady. I will be presenting my thesis on an animated portrayal, the normal placentation, and the pathophysiology of placenta accreta spectrum. I work with Dr. Aaron Gomez, Lydia Gregg, and Corey Sendo. Placenta is a temporary organ that forms during pregnancy. It attaches to the uterine wall, provides nutrients and oxygen to the fetus. Placenta accreta spectrum, or PAS, is a potentially life-threatening condition in which the placenta is abnormally adherent to the uterus. This spectrum is categorized according to the depth of myometrial invasion. The incidence of PAS has... Sorry, Stacia, can you pull, or Corey, do you know how to pull this back up? Let's see. Sorry, folks, I was just trying to get the cursor off.
So should we close out and start?
Yeah, I'm not sure. Oh, okay. Google since the 1980s, from 1 in 1,250 births to 1 in 272 births. Risk factors include prior C-sections, placenta previa, where the placenta covers the cervix, and other uterine surgeries. Risk of PAS increases exponentially from multiple C-sections. The arrow in the illustration indicates where the placenta has invaded the urinary bladder, known as placenta percutaneous. Unplanned PAS delivery is catastrophic due to massive peripartum hemorrhage. Women treated in tertiary care centers are less likely to require large volume blood transfusions, undergo subsequent surgical procedures, and experience concomitant morbidity. Patients at these centers are cared for by a multidisciplinary care team with specialists with expertise in diagnostic and interventional radiology, high-risk obstetrics, urology, and blood banking, to name a few. Animations of normal placental development exist. However, none depict PAS pathophysiology or the invasion of extravillous trophoblasts. Currently available 3D animations on normal development use complex medical terminology that is less suitable for patients. The goal of this thesis was to depict normal placental development and abnormal placentation in PAS at cellular and macroscopic levels, while guiding patients through illustrations regarding surgical management of PAS. The underlying goal is to encourage multidisciplinary care. This will serve to increase patient and referring physician understanding of how abnormalities in PAS may complicate delivery and pose significant risks to patient and fetus, particularly at delivery. The primary audience is PAS patients and referring clinicians. The secondary audience is radiologists, urologists, general OB/GYN, pathologists, surgeons, and medical students. This is a general overview of the materials and methods. It began with the literature review, and creating a storyboard and script, and then 3D and 2D assets, finally animating and compositing. If PAS is detected in routine ultrasound at 18 to 20 weeks gestation, the patient is sent for follow-up imaging. MRI and CTA dictate a unique surgical plan for each patient. Dr. Aaron Gomez, our preceptor, reviewed MRI and CTA imaging to compare normal and abnormal placentas, as well as the maternal organs and tissues that were affected by placental invasion. Cesarean deliveries of 2 patients with PAS were observed at the Johns Hopkins Hospital. In both cases, placenta precreta had invaded the urinary bladder. Each patient underwent a cesarean hysterectomy, and one required cystotomy repair. These observations helped to understand the risk of hemorrhage, surgical complications, and the benefits of the multidisciplinary care team. To understand pathology, I reviewed histology slides of non-placentas and PAS with the pathologist. This helped understand the cell types and structure of placenta and uterus. These, along with photographs of gross specimens, were referenced to create 3D cellular landscapes and the 2D illustrations. The script was developed, sketches were created to visually depict each line of narration. The storyboard was reviewed by advisor, preceptor, pathologist, and PAS patient. This underwent multiple iterations incorporating the reviewer's feedback. This was a software used to create the animation, 3D slicer, ZBrush, Cinema 4D, as well as After Effects, Photoshop, and Audition. The result was a 6-minute animation with 3D and 2D components. Now I will play a clip of normal placental development.
During pregnancy, a new structure called the placenta grows to deliver oxygen and remove waste from the fetus's bloodstream. The placenta begins as a shell of cells around the embryo called trophoblasts. This attaches to the lining of the mother's uterus called the decidua. The trophoblasts become several different types of cells as they grow and divide. Some trophoblasts become structures inside the placenta called villi. As they grow throughout the pregnancy, the villi branch into the shape of a tree. Inside the villi, blood vessels develop that will connect to the baby's umbilical cord. At the base of some of the villi, another type of trophoblast helps hold the placenta in place. Normally, these cells move into the decidua. Chemical signals from the lining of the uterus tell the cells how far to travel. Some travel a short distance into the muscle of the uterus, which is called the myometrium. These cells also take control of the arteries that will carry oxygen and nutrients to the placenta. They make arteries larger, allowing them to carry more slow-moving blood to the fetus, which helps it grow. About 12 weeks into the pregnancy, the placenta begins to do its job as blood from the mother surrounds the tree-like villi and delivers oxygen and nourishment to the fetus. As time goes on, the placenta will continue to grow as it supports the fetus.
Now I'll play a clip on placenta accreta spectrum.
Placenta accreta spectrum, or PAS, occurs when the placenta does not attach normally to the uterus. It can be divided into 3 categories based on how deep the attachment goes: placenta accreta, placenta increta, and placenta percreta. PAS increases the risk of serious bleeding during childbirth due to the large volume of maternal blood in the placenta. PAS can be caused by scarring in the uterus, which can happen after surgeries like cesarean section. PAS usually happens low in the uterus at the same location as the C-section scar. In areas with scar tissue, the lining of the uterus can be abnormal, which might make it easier for trophoblasts to invade. In placenta accreta, the placenta attaches directly to the muscle of the uterus instead of the uterine lining. In placenta increta, the placenta invades the muscle of the uterus. In the absence of a normal uterine lining, the placental cells continue their journey deep into the muscle of the uterus. Because of this, larger arteries deeper in the uterus also grow and change. Lastly, in placenta percreta, the placenta invades the full depth of the uterus, all the way to the outer layer, called the serosa. When this happens, the placenta may be able to grow into other organs in the pelvis, such as the bladder, and may also be able to influence blood vessels outside of the uterus.
A novel contribution was animating extranodal trophoblast invasion. By comparing normal placental development, where the uterine environment regulates the placental's invasive capabilities, to PAS, where disrupted decidua allows for hyperinvasion and deeper maternal artery remodeling. Also highlighted were the risk factors, particularly the C-section is the primary risk factor. Women of color undergo C-sections at higher rates, and therefore a patient of color was depicted. This is also animated for a patient audience, so the style and calm color palette were designed for patient sensitivities. The terminology, timeline, and concepts were simplified, as well as the pacing of the animation to facilitate comprehension. With further discoveries of underlying mechanisms of PAS, the animation can be developed for medical and scientific audiences. The animation will be accessible on the JHH Obstetrics website, as well as my own website. In conclusion, I created a novel resource for women with PAS, which visualizes and narrates the complex process, normal and abnormal placental development. This animation serves as a call to action for patients to seek care at a specialized center by describing the risks, mechanisms, and complications of PAS, while affirming clinicians will recognize the benefit of a multidisciplinary care team. The intention is to improve healthcare outcomes by planning for the unique challenges of each PAS patient. Thanks to my preceptor, Dr. Aaron Gomez, and my advisors, Lydia Gregg and Corey Sandone, for all their help with the thesis. Those are my content advisors, faculty, and classmates. Thank you for your attention.
Congratulations, Jason. It looked great. Shirley Lee, our next presenter, studied at the University of Toronto, where she received her BS in comparative physiology prior to enrolling in our program. She was introduced to Unity last fall and sought additional training in this software to support her thesis work, for which she was recognized as a Vesalian Scholar by the Vesalius Trust last month.
Thanks for the introduction, Corey. I'm Shirley. I'll be presenting my master's thesis, exploring the sinonasal cavity in 3 dimensions, teaching otolaryngology surgical trainees clinical anatomy using a web-based learning resource. I would like to thank my preceptors, Dr. Nicholas Rowan and Dr. Annie Saraswatla, for this wonderful opportunity. The sinonasal anatomy of the sinonasal cavity is composed of 4 pairs of paranasal sinuses that are connected to the nasal cavity, making up a network of airflow and drainage passages that functions to clean and humidify inhaled air. Within the nasal cavity, the superior, middle, and inferior turbinates are paired bony projections from the lateral nasal wall. The lateral nasal wall contains important anatomic landmarks that needs to be accurately identified during surgeries to avoid complications. During endoscopic sinus surgeries, surgeons are required to operate within the complex nasal space under limited endoscopic angle while minimizing neurovascular manipulation. Pre-existing anatomical variation also needs to be evaluated by studying radiological imaging before surgery. The lack of a thorough understanding of the anatomy may lead to intraoperative disorientation, which poses risk to patients. However, existing teaching resources for sinonasal anatomy are limited to 2D media, which include traditional textbook illustrations, computer tomography scans, and multimedia resources such as online surgical videos, through which the spatial relationship of the sinonasal cavity is poorly communicated. Although 3D visualization has been explored to develop clinical training simulations and CT-derived 3D models being used for clinical education, it has never been incorporated effectively into didactic materials to teach sinus anatomy. To address the need for improved teaching resource for otolaryngology surgical trainees, the objective of this thesis is to create a web-based interactive resource that aimed to use a 3D schematic model to teach clinical sinonasal anatomy and subsequently improve surgical training outcome. As study confirmed the effectiveness of combining 3D and 2D visualizations in teaching sinonasal anatomy, in this project, an interactive 3D schematic model is paired with 2D CT images and surgical videos to maximize learning outcome by improving 3D spatial knowledge of important landmarks and correlations to 2D visualizations. For execution of this thesis project, the first step involves design of the didactic contents. This resource consists of two learning modes. The Explorer mode will feature a 3D schematic model paired with a CT radiological visualization. CT reconstruction model that can be manipulated in concert, which is combined with scrollable CT image series that helps to improve correlations to radiological visualization. Whereas in clinical mode, it features a 3D schematic model paired with surgical video and scrollable CT image series, which serves to improve spatial knowledge under endoscopic perspective. And next, 2D and 3D assets were developed, which involved the development of a schematic model based on visuals created by Weiss et al. In a publication in 2012. A CT reconstructed 3D model derived from a CT data set of an anonymous patient following an IRB approved protocol, and processing and labeling CT images from the same CT data set. And finally, the surgical video clips for clinical mode are prepared and provided by the preceptors of this thesis project. The software used to develop this project include Cinema 4D, D2P, and ZBrush for creating 3D models. Adobe Photoshop was used to process and label CT images, and Illustrator was used to create 2D assets for user interface. And finally, Unity was used to compile everything into an interactive application. For results, beginning with 3D schematic model created to highlight the spatial relationship of anatomic landmarks, which included the middle turbinate, highlighted in red here. Oops. and associated lateral nasal wall structures. Landmarks associated with sphenoid sinus, as well as critical skull-base structures, were also depicted. And next, the user interface was designed, which consists of 4 panels presenting different types of didactic materials. With a navigation panel on the left that gives users access to switch between modes and a list of structures. In the Explore mode, the 3D schematic and CT reconstructed models are presented alongside the scrollable CT image series in coronal and axial planes. A banner at the top of each panel indicates the type of content with a full screen button located on the right. Here I will be showing a demo of the interactions in the Explore mode. The 2 3D models can be manipulated in concert. When left click and drag on one model, both models can be rotated. And scrolling mouse wheel will result in zooming of the models. Right click and drag on model enables panning of the models. And within each 3D panel, a reference cranium is placed at the bottom left to help users orienting their view. And within each CT image panel, a slider allows user to scroll through the image sequence. Upon activation of the slider, the corresponding CT plane will appear in the 3D reconstructed model that indicates the location of a CT image slice. The CT planes can be hidden via the toggle button situated on the banner of the 3D reconstructed panel. Structures can be selected and highlighted by clicking on structure names within the navigation panel or by double-clicking on 3D schematic model. The selected structure will be highlighted across all panels. And finally, structures can be hidden by accessing the toggle buttons in the navigation panel. As users switch to clinical mode, a panel featuring surgical video will replace the 3D reconstructed panel with a list of surgical videos being added to the navigation panel. The rotation of the 3D schematic model will be limited to a confined range that is consistent with the limited endoscopic angle during surgery to mimic surgical perspective. Overall, the resulting interactive resource provides an interactive and novel learning experience where users can manipulate structures and explore sinonasal anatomy in 3D space. The use of an interactive 3D schematic model highlighting the spatial relationship of important landmarks serves to improve understanding of clinical relevant sinonasal anatomy. The incorporation of CT images and surgical videos helps to bridge the gap between 3D and 2D radiological and clinical visualizations. This research represents the first prototype that uses a combination of interactive 3D and 2D radiological visualizations as a didactic teaching tool, which offers a novel framework for developing clinical teaching resource and can be applied to other surgical subspecialties where a need exists to correlate information across a variety of media to improve anatomy learning. And finally, for in the future, the resulting interactive resource will be made available through the Johns Hopkins Department of Otolaryngology head and neck surgery website that can be easily accessed by surgical trainees, physicians, and medical students across the country. Application performances and user interface will be refined based on users' feedback. And for future development, additional didactic content such as clinical notes and media visualizing dynamic physiological processes of the sinonasal cavity can be implemented for more comprehensive learning experience. And lastly, I would like to take the time to thank my faculty advisor, Juan Garcia, and my thesis preceptors, Dr. Nicholas Rowan and Ani Saraswatula, for your generous help and guidance over the past few months. Vasilis Trust for funding this project, Patrick for technical support, and Dr. Poynton for helping with preparing this presentation. Thank you, and I would like to take any questions or comments. Any questions, comments? Thank you.
I just want to commend you on all the work that you've done, particularly with both understanding the anatomy and of course the technical software that you had to use to put this together. I think it's just incredible the amount of work that you've been able to present in this season. So congratulations.
Thank you, Jenny. Thank you so much.
Tina Wang earned her BS in microbiology and immunology from University of British Columbia. Tina's interest in data visualization and was drawn to this thesis topic because for the rich data sets and novel opportunities it offered. She's an outstanding distiller and designer of information, which you will see in her presentation.
Sorry, give me one sec to find my mouse. Okay.
Thank you, Corey, for the introduction. My name is Tina, and the project I'll be presenting today is 3D visualization of genetic mutations in pancreatic intraepithelial neoplasia. I'd like to extend my gratitude for Dr. Rubon and Dr. Wirtz for their guidance as my preceptors for this project. Pancreatic ductal adenocarcinoma, or PDAC, is one of the deadliest cancers in the world. It is also a cancer of the epithelial cells that line the pancreatic ducts. Although pancreatic cancers, consisting of mostly PDAC, make up a small percentage of all cancer cases, it is associated with high morbidity with a 5-year survival rate of about 11.5%. PDAC is often diagnosed at advanced stage with poor prognosis. It is associated with late onset of symptoms and a lack of, this is also due to late onset of symptoms and lack of effective early disease detection. PDAC arise mostly from these precursor lesions called pancreatic intraepithelial neoplasia, or PANN. This image you're looking at is a histological cross-section of a pancreatic duct. The white space you're seeing in the middle is the lumen. The cells within the green circles are the PANN cells, or cells that have become neoplastic. As PANNs develop, genetic mutations accumulate. This is a diagram showing the different stages of PANNs as they develop into invasive PDAC. Though the genetic mutations that drive cancer development have long been identified, little is known regarding the spatial distribution. of these genetic mutations. And this is also due to cancers often being studied in 2 dimensions. So the image on the right-hand side is a 3D printed model of a panon. And you can see that panons often take on the complex branching patterns of the pancreatic ducts from which they arise. If we look at cancers simply in 2D, 2 seemingly distinct panons may be connected in another plane, and we may not know that. And this can limit our understanding of how panons develop and how genetic mutations in certain regions of panon drive panon and cancer development. Hence, it is very important to look at the problem in 3D. So the Rubon Lab and the Works Lab here at Johns Hopkins University have developed a novel workflow called CODA to study cancers in 3D. The workflow uses machine learning to identify and label different pancreatic tissues in histological slides. The labeled cells are then digitally compiled and reconstructed into digital volumes, as seen here. Once the panon cells have been identified, cells within these volumes were harvested and sent for DNA sequencing. Panons were also further subdivided into different regions for deeper resolution of lesion heterogeneity. And these are the genetic mutations that have been identified in this particular sample. Now that we have the volume data, we know what mutations exist in these panons and we know where they are located. The question is, how can we visualize the distribution of these genetic mutations in a clear and organized way? So the approach that we took is a 3D scatter plot approach. The image on the left-hand side shows an example of the 3D scatter plot. This type of plot has long been used by scientists to visualize distribution and clustering of data across different parameters. Some considerations for our visualization include how can we preserve the topology of organic structures and how we can minimize crowding of labels. For types of visualization were created. First were still images that can be published alongside journal articles. Second are turntable videos that can be shared during PowerPoint presentations. Third is an interactive applications that allows the researchers to manipulate the data for a more robust understanding of the data. And fourth is a promotional image that can be shared across social media to elicit interest. Software used are Cinema 4D, ZBrush, Unity, and Adobe Creative Suite. First raw data volumes were brought into ZBrush to be optimized. Spheres representing genetic mutations were then mapped onto the surfaces of the panels. Different genetic mutations were assigned different colors. 2 modes were created. First is a no prevalence mode where all the spheres were of the same uniform size. Second is a prevalence mode where prevalence of each genetic mutations in different regions were reflected in the size of the spheres. The visualization was then assembled within an interactive user interface. For the final visualization, here's a tiling of all the still images that were created. And here's a turntable that was created. And within the user interactive application, user can rotate and zoom in on the model. You can zoom out and reset the rotation of the model. You can toggle the different structures on and off. There's also a diagram at the bottom that shows the rough distribution of the genetic distribution. and that diagram can be toggled on and off. The individual genetic mutation can be toggled on and off individually, or they can be toggled on and off all at once. When only one genetic mutation is toggled on, you can toggle labels that display the prevalence information of each region on. And when you hover your mouse over the regions, genetic mutation information and their prevalence information were displayed at the bottom. Last but not least, there is also a button that switches between the prevalence and no prevalence mode. And here's a promotional image that was created. So for this project, we pioneered a novel 3D visualization of 3D spatial distribution of genetic mutations. In addition to the data set that was shown, 2 additional data sets were visualized in a similar manner. Some future considerations for the project include how can we expand the visualization to accommodate for other parameters as well. These parameters include RNA expression, protein expression, change of expression over time, and accumulation of genetic mutations over time. In the future, a complete platform could also be made that takes standardized input from researchers and returns a standardized set of visualizations that systemizes the reporting of similar 3D data and facilitates discussion amongst researchers. Again, I'd like to thank the following people for their help and support on this project. Specifically, I'd like to thank Dr. Rubon and Dr. Wertz, who serve as my preceptors, Jenny Fairman, who is my faculty advisor, Dr. Keeman and Dr. Braxton, who provided the data, Patrick McCarthy, who provided technical support for the project, the Vesalius Trust for funding the project, and the faculty in class 22 of Arts as Applied to Medicine. Thank you so much. Now I welcome any questions and comments.
It's a real pleasure working with you, and I want to congratulate you. It's something that's complicated in 3 dimensions, and then you can add on all these genetic changes, where they occur, the genes and their prevalence, and you create something that's really visually stunning, but more importantly, educational, and highlights the extraordinary genetic heterogeneity of these regions. So congratulations again, real pleasure.
Thank you so much, Dr. Rubon. Thanks for coming as well.
That was really neat, Tina. How did you make the balls change with the prevalence? And I missed what you used for the interactive. That's really neat.
Thank you, Jeff, for the question. So the question was, what was used to build the interactive? So I used Unity to build the interactivity. So there were 2 models that were made for the spheres. One is with the bigger, different sphere sizes, and one is where all the spheres are of the same size, and it's just within the Unity, it toggles between the 2 modes. Yeah. Any other questions? Thank you so much.
Kelly Lim received her medical degree from Imperial College London. Dr. Lim's experiences with patients reinforced for her the importance of effective medical communication, leading to a shift in her career path. To put the work you will see in perspective, Dr. Lin had done absolutely no 3D animation prior to attending our program. She's incredibly talented. Let's have a look.
Thank you for the introduction, Corey. My name is Kelly Lim, and I'll be presenting my thesis, The Role of Signaling Networks in Cell Migration. I'd like to thank my preceptor, Dr. Peter de Brutis from the Department of Cell Biology. Cell motility is a polarized process that involves cell shape change by formation of protrusions from the leading edge and the retraction from the trailing edge. Protrusions come in many different shapes and sizes, ranging from finger-like filopodia to sheet-like lamellipodia, and they play a key role in important cellular activities such as migration, division, and phagocytosis. As you can see in this diagram, which is showing a cell with lamellipodia, a cell can be divided into two parts, the front edge in blue and the trailing edge in pink. Actin polymerization takes place at the front of the cell and makes up the force that drives the protrusion out from the cell body. On the other hand, at the trailing edge, actin filaments interact with myosin, leading to actomyosin contractions that result in retraction. However, actin polymerization and actomyosin contractions only induce shear force that leads to a transient change in the cell shape. Without signaling networks, the protrusions are not sustainable and the cell cannot maintain its shape. The shapes and locations of the protrusions are determined and maintained by signal transduction excitable networks, STEN for short. They consist of receptors, small GTPase proteins, and phosphoinositide lipids locating at the inner surface of the cell membrane. Front molecules such as RAS and PIP3 organize at the cell's front edge, leading to actin polymerization and protrusion, while back molecules such as PIP10 and PIP2 dissociate from the protruding regions and organize at the rear of the cell, leading to actomyosin contractions. Examples of these complementary accumulations are shown in the diagram on the left. And as highlighted in circle, the front and back activities are not confined to the morphological front and back lesions of the cell. They can take place anywhere in the cell, leading to either protrusion or retraction. The goal of the project was to visualize complex cell migration mechanisms using a narrative 3D animation in order to educate viewers and suggest direction for future research. The primary audience includes cell biology and medical students. The secondary audience groups were researchers in related fields, educators who would like to use the animation to supplement other teaching materials, and the general public with an interest in the topic. First, books, peer-reviewed scientific papers, and data provided by the content expert were extensively reviewed. Following research, a script was devised. Care was put into making the story engaging, but not distracting. Once the script was confirmed by the preceptor, narration was recorded by a professional voiceover artist. Photoshop was used to make a storyboard, then an animatic was developed to check the flow of the animation. Assets were then built using Pymol, ZBrush, Cinema 4D, then animated in Cinema 4D. Finally, the animation was rendered by a third-party renderer, Redshift, then composited and edited up in After Effects. I'd like to present a scene from the animation to show the workflow. First, the storyboard and an animatic were created using rough 2D images. Then using them as a reference, 3D models were built in Cinema 4D and ZBrush. Materials and textures were added. And finally, lighting and cameras were set up by Redshift. The final animation is 3 minutes and 28 seconds, excluding the credit scene. It can be accessed on my website or the cell biology website at Johns Hopkins. And now play the animation.
Life is dynamic. Living cells are always changing and transforming themselves in one way or another. For instance, many cells are constantly changing their shapes by displaying a variety of protrusions that are important in cellular activities such as migration, division, and phagocytosis. Examples of these shape-altering protrusions include finger-like filopodia, broader pseudopodia, and sheet-like lamellipodia. What triggers these extensions and determines their features? The mechanical forces that drive the protrusions outward from the cell body are mediated by combined actin polymerization and actomyosin-based contractions referred to as cytoskeletal activity. However, cytoskeletal activity alone produces only transient, small extensions or puncta or ruffles, which cannot effectively move or reshape the cell. The extensions attain their dynamic shapes and locations through the action of a network of components, including small GTPase proteins and phosphoinositide lipids, collectively referred to as signal transduction. Upon activation, the network components quickly organize into front or back regions on the inner surface of the membrane. Front activities such as RAS, PI3 kinase, and PIP3 locate at the tip of the protrusions and promote actin polymerization, while back molecules such as P10 and PIP2 leave the active regions and accumulate at the trailing edge of the cell, leading to actomyosin-based contractions. The protrusions expand as the region's network fires sequentially, sweeping across the inner face of the membrane like a laterally moving stadium wave. Increasing or decreasing signal transduction activity can elevate or decrease the speed and range of wave propagation, converting pseudopodia into wider lamellipodia or narrower filopodia-like structures. The spontaneous firing of the signal transduction network causes the cell to move in random directions, but external chemical, mechanical, or electrical signals influence this spontaneous firing to guide the cell and direct its migration and behavior. A highly orchestrated control of these dynamic changes in cell shape and motility not only guides immune cells to a pricked finger, but bring form to the embryo.
Okay, I'll just play the last about 20 seconds of the animation.
Highly orchestrated control of these dynamic changes in cell shape and motility not only guides the immune cells to a pricked finger, but bring form to the embryo, wire the nervous system, and have clinical implications in wound healing, tissue regeneration, and cancer metastasis.
Through a 3D animation, my project has visualized the complex interactions between the signaling molecules, cell membranes, and cytoskeleton. The biggest challenge was processing the complex topic, which is still not entirely understood. Refining and editing large amounts of information down to a short, succinct, engaging story was another big challenge. Our future direction of the project would be to build additional multimedia tools, such as an interactive website or smartphone application, which will help broaden accessibility. Topics that were only briefly mentioned in the animation, such as cytoskeletal activities, may be explored further in subsequent animations or via the interactive website. I'd like to thank Dr. DeVortis, my preceptor, and David Winnie, my faculty advisor, for their help and guidance through the project. I'd also like to thank all the faculty members and my fellow classmates. I now welcome any questions and comments. Thank you.
got the same comment. That was a beautiful animation. I just wanted to hear what you thought of working in Redshift.
Redshift is an amazing renderer. It takes time to get used to it because there's just so much it can offer, but it's not difficult. There's just a lot to learn, and once you're used to it, it's very simple to use. It's a really nice renderer. Thank you.
Jennifer Wang, our last presenter, earned her BS in neuroscience from the University of Michigan. She's interested in bridging the communication disconnects between clinicians and patients using visuals to explain complex ideas. Her thesis had an assessment component for which she obtained an IRB, and she'll share the results in her outstanding presentation.
Thanks for the introduction, Corey. Let me pull up the slides. Right. Hi, everybody. My name is Jennifer Wang, and my thesis project is called Understanding Percutaneous Cholangioscopy, Designing and Evaluating Multimedia Tools for Patients and Physicians. I had the pleasure of working with my preceptor, Dr. Harjeet Singh, an interventional radiologist in the Department of Radiology, and my faculty advisor, Jeff Day. Percutaneous cholangioscopy is a minimally invasive interventional radiology procedure that is used to treat biliary obstructions like gallstones. Patients that receive this procedure typically have a drainage catheter already in place through the abdominal wall to drain the buildup of bile. This catheter is then replaced percutaneously with a scope. Gallstones can then be directly visualized and broken up using a laser and removed to restore biliary flow. This procedure is an option if patients aren't eligible for traditional surgical interventions or have significant comorbidities. So here is a current Google search of percutaneous cholangioscopy. And you can see that most of the results are complex medical imaging techniques that are used during the procedure. And there are very few visual resources that are designed to teach patients as the primary audience. So due to the lack of this familiarity and accessible information, this procedure is still underutilized for many eligible patients and by referring physicians who may have potential patients for this procedure. So in our solution, we propose to create visual materials that would be both accurate and approachable for patients that would be receiving this procedure. There's also been an increasing interest in using standardized visual aids to reduce gaps in communication in patients with varying levels of health literacy. Many studies have also shown that physicians routinely rely on visuals to teach patients and also to communicate with other professionals. Other studies have also confirmed that standardized visual aids helped patients increase their knowledge retention and information recall about the procedure they were to receive. So these studies supported our plan to design images, still images, a pamphlet, and an animation that would be helpful for our target audience of patients and referring physicians. We also designed a test to confirm whether the addition of these visuals was useful, and we measured 3 parameters in our study: retention, engagement, and preference. Our ultimate goal for this project was to increase awareness of percutaneous cholangioscopy as a potential treatment option. A script was drafted under the guidance of Dr. Singh to explain the procedure with information that would be included in a patient clinical visit. The script was then used to create a storyboard using Storyboarder and Procreate for our planned animation. I used Adobe Illustrator, Photoshop, and Cinema 4D and InDesign to create still images that were used for both the pamphlet and in the animation. The animation was created using After Effects, Audition, and Media Encoder. And now I will play the animation.
Percutaneous cholangioscopy is an interventional radiology procedure that can help treat gallstones. Patients with right upper quadrant pain that are diagnosed with gallstones often have a tube placed in the gallbladder to help drain and relieve the blockage from the stones. This tube is exchanged for a larger tube in order to prepare the patient to come back in the near future for the percutaneous cholangioscopy procedure. For that procedure, we will take the previously placed tube out, and through the tube pathway, a scope with a built-in small camera is passed into the gallbladder. Using a laser, the stones are broken up into smaller fragments. A basket is inserted and the fragments are removed through the tube pathway. Once the stones are completely removed, the drainage of the gallbladder is checked, much like pipes are flushed, to make sure there are no blockages from any remaining stones. When the session for the day is completed, a new tube will be placed. If the drainage catheter is functioning, we will ask you to come back a couple more times for a staged removal of the catheter. Additional sessions may be needed to remove all the stones. Possible complications include infection, bleeding, dye reaction, damage to the gallbladder and the surrounding structure, as well as a reaction to the sedation medication, which can include a change in your heart rate or your blood pressure. Percutaneous cholangioscopy can be an effective treatment if you can't undergo traditional gallbladder surgical removal and wouldn't want a tube in place long term. If you think you would be an appropriate candidate, you can ask your provider to refer you to an interventional radiologist.
So with our media completed, we continued with our IRB approved study. We ran a pilot study for the scope of this thesis project and collected data through a Qualtrics survey. We tested two target populations, a lay audience in the non-physician group with the sample size of 19 and IR residents with the sample size of 12. In block 1 of the study, each participant received one of two randomized interventions, either a text-only explanation of the procedure or a text plus supplemental images explanation. We measured knowledge gain through pre and post testing, and we measured engagement using a survey. Following this, in block 2, the whole group of participants were then presented with 3 methods of explaining the procedure: the same text explanation, a patient ed pamphlet, and an animation excerpt. So recall that only half of the participants had received the images in the first text-only explanation. And then we asked each group to rank their preferred method of choice, or preferred method of explanation. So these graphs show the test scores in both intervention groups. The light teal bars represent pre-test average scores and the dark teal represent post-test average scores. Each group is split by intervention type, either the text or the text and images. And in the non-physician group, the post-test average scores were slightly higher than the pre-test scores, but the results weren't significant. And in the IR resident group, there is no change in either pre or post-test score. So for the engagement survey, we use a Likert scale from 1 to 7. Each dot on this graph represents the average score of our survey questions, and the graph is split by target group. The higher the average score represents, a higher engagement. Both intervention types had overall high engagement scores, and the text and image intervention type had a slightly higher engagement score. Finally, we compiled the preference rankings of the 3 explanation methods from both groups. The rankings ranges from darkest purple, representing a ranking of 1, to the lightest purple, representing a ranking of 3. So looking at the dark purple bars, you can see that the majority of the non-physician group ranked the animation as their first choice for explanation method. And in the IR resident group, half ranked the animation and half ranked the pamphlet as their first choice. When looking at the lightest purple bars, you can see that the text explanation was the least preferred method for both groups. Overall, our results indicate that most people in both groups preferred visuals to supplement the explanation of the procedure. People generally responded favorably to the media created, writing that the explanation was clear and concise, easy to understand and follow, and the addition of images was useful for visualizing the procedure. Another recurring comment that we received from both groups was that if they received the text-only explanation of the procedure in the first part of the test, it would have been helpful to have some sort of visual or image to supplement that explanation. So from our pilot study, we were able to collect preliminary data and test the functionality of our survey. We established a novel patient education design model for explaining percutaneous cholangioscopy using an effective and approachable style for patients. Our preliminary data indicated a positive reaction to adding media to supplement the explanation of the procedure, and the pamphlet and animation created in this project will be available in clinic and online. We plan to continue with our IRB study and test patients in clinic and recruit referring physicians who are not in the field of IR. We also possibly plan to present our findings at the annual Society of Interventional Radiology Conference and submit a paper to the Journal of Vascular and Interventional Radiology. I'd also like to take the time to thank my preceptor, Dr. Harjeet Singh, and my advisor, Jeff Day, for their support and guidance to this whole project. Thank you to CLS Trust for funding this project and the faculty in our department, and of course, my fellow classmates. And I now take any questions or comments. Thank you.
Again, I just want to make a comment, really. I just want to compliment you on your really strong storytelling skills, and also I just love your color palette and style that I've seen just grow along the way ever since 2D animation now Thesis. So again, congratulations on a really well-told story, and of course on all the research that you're able to disseminate. It's great.
Thanks, Jenny.
Wonderful work, Debbie. I had a question for you. What made you decide on the style that you used, particularly some of the secondary animation?
So when we were, great question, thank you, Gabby. The question was what went into the choice for the style of the animation and some of the secondary animation choices. When we were going through different ideas of how to approach this visually, I think we wanted to keep a style that was easy for people that aren't in the field of interventional radiology to understand, and also kind of keep it like a friendly style so that it's inviting, because sometimes these procedures can be really scary and unknown to patients. So.
More comfortable being able to have this kind of navigation, having this kind of visual is super valuable.
We do have a couple of comments from our YouTube audience. Dr. Jody Cooper, was there any space for survey participants to make specific comments about the animation, and what did they say?
Yeah, so we included an area for comments in our engagement survey. So that was actually given before they had seen the animation, so we didn't actually include any, but that would be a good addition to possibly include in our next iteration.
Also, Mitchell Wassel says, to what extent did you have a trade-off medical accuracy for simplicity with creating the visuals?
So like we saw in the Google image search, a lot of the images were very or just the medical imaging techniques, so using like a cholangiogram or just seeing the endoscope view. So we wanted to keep as little graphic detail as possible so that it wouldn't be very jarring for patients to look at.
Jennifer, I just want to say it's great to work with you. She worked really hard on her IRB, and she wrote it all the way until a couple weeks before she had to turn in her thesis. It might be neat to share what the next part of the study is, if you're willing to, and yeah, what Dr. Singh is going to do in clinic.
Yeah, so far all of our results were obtained online, so we sent out emails and collected results digitally, but one of our goals was to recruit patients in clinic. So Dr. Singh will be seeing these patients who would be coming in to have this procedure and then giving the survey in person. So that would be interesting to see if there's a difference. Thank you.
All of you did an excellent job, and I want to thank our preceptors for the thesis projects this year. It's a lot of time and expertise invested. I want to thank the faculty advisors and the staff in the Department of Art as Applied to Medicine, particularly Daisha, for the technology to bring this to our YouTube audience. If you're a potential preceptor, please contact me. I am accepting very simple one-page proposals, and I'm happy to talk about ideas, accepting these through May 16th for our 7 talented students who are in our rising second years. I would also like to invite everyone to join us for a reception in the foyer, but before we do that, let's please give our class of 22 one last round of applause for their. Thank you.